And another thing that you can do with this is that you can build into a single instrument, like we did with physical optics, which we call the smart scalpel. It had two lasers. It had a diagnostic laser using Raman spectroscopy, and it had a cutting laser. And the diagnostic laser would look 5 millimeters ahead of where the cutting laser would be. And it would detect by the signature what the tissue was. The first experiment was, can we cut tissues and diagnose blood vessels underneath the peritoneum that you cannot see and turn off the laser before it cuts them? The answer was, piece of cake. That's closed loop feedback. And that closed loop feedback works at 50 milliseconds. The human brain isn't even that fast. So we've got systems that can actually do diagnosis during treatment, and it's able to detect whether or not there's something good or bad there and automatically turn off the instrument before a human's even aware of it. So when you look at these kind of opportunities of information and energy blending together to do things that humans cannot do or do with great difficulty. Here's high-intensity focused ultrasound. We saw other ultrasound. You turn on the ultrasound, it focuses the beam and coagulates the tissue. If you use enough energy, it will actually vaporize the tissue. Military got interested in this. This is the Sonosite 180. That was another one of our portable ultrasound projects from the Department of Defense. And we coupled that with high-intensity focused ultrasound to stop internal bleeding. This is a pig, and this pig is going to have internal iliac artery and internal artery lacerated. This pig dies in 15 minutes once that's lacerated. So here is the Doppler, and now you see the laceration has occurred. This pig will die in 15 minutes, but we have HIFU. And so a button is pressed, you can tell by the interference here, on the HIFU. And then when you turn the Doppler ultrasound back on, there's no more bleeding. This pig was saved. A surgeon would have to cut them open, be able to put clamps on them, sew them shut, and so on and so forth, but we were able to do it simply by taking our ultrasound. Now, does that sound familiar? Somebody's out on the highway and they're bleeding to death. They've got a lacerated liver or something, and the medic runs up and goes, zap, and they're cured. Star Trek, anyone? No, it's not. That's the technology that's in the laboratory today that our medics are beginning to use as we go out on the battlefield. It's hard science, and it's science that's based on information technologies combined with energy. So there are a number of other robotic surgical systems out here. This is the one from Poland, from Warsaw, Poland, called Robin Heart. It's by a combination of an engineer and cardiovascular surgeons there. It has this little preliminary here, and this is their early animal trials on this. It's a very interesting system. What you'll notice, it's different enough so that they can get a patent on it, but it's similar enough, if you will, to what the Da Vinci system already has. The reason that I want to show you this point is that the systems that we are designing today, and there's this one, and then there's Sophie, and there's XLAP, and so forth. There's about 4 or 5 robots being developed around the world, but they're not too much different than what Da Vinci has. And so what I believe we need is we need a new approach, a different kind of a robot, one that's smaller, lighter weight, less expensive, and easier to use. Da Vinci's an incredible system, but this one is mainly just following what it's doing rather than developing something new. But here's something that's very interesting, something extraordinarily practical. Please meet Penelope. Actually, Penelope 2. Penelope is a pick-and-place robot, just like the one I showed you at the very beginning. But it has very sophisticated image recognition and voice recognition. And it does what a scrub nurse would do. And so you see there to the right is Michael Treat. He'll say, put down the clamp and say, scalpel for the right hand. The robot picks up the scalpel and hands it for him. He grabs the scalpel and starts cutting. The robot looks around, scans the area, finds where the clamp was put down, takes it up and puts it back on there. That's what my scrub nurse does. And I always wondered, now here standing next to me for what, 4, 5, 6 hours, is this nurse with 5, 7 hours, years of education and training. And what do they do for 4 or 5 hours? Well, they pick this up and put it in my hand. I set that down, they pick it up and put it on a tray. Can you imagine standing 4 to 6 hours after you've had that much education? I don't know how they do it. I have to congratulate them for it. We've got systems that can do that. We should relieve them of the tedious tasks, the repetitive tasks that really don't require a lot of intellectual or interaction. Free them up so they can get more time with their patients and be able to do things much more efficiently. So, we decided that we've got the Da Vinci robot, and Michael was building Penelope, and we looked around out there and discovered that most robots, when they need something new, whether it be a new instrument or a new supply of some kind, they don't have a person there. As a matter of fact, they're all got this great big yellow tape preventing humans going anywhere near them. What they have is something called a robotic cell, which I'm sure you're all familiar with, where you have multiple robots working together. And when they need a new tool, they have a tool changer. When they have a new supply, we don't have people running and giving them nuts and bolts. They've got supply dispensers. So we said, why don't we do that in healthcare? We can do this. It already exists. It's only 25 years old. It's in most manufacturing facilities. So we decided we were going to build an operating room that had no people except, for example, the patient. And this is the operating with no people. Here is the Da Vinci robot. This is a smart bed I don't have time to tell you about. This is a pharmacy robot called Quick Script that dispenses medical supplies, just like robotic systems will dispense tools and so forth. And this is a tool changer that was built. And as I mentioned before, when the surgeon said scalpel for the right hand, it grabs the scalpel, removes the old one, and puts the new one on. When it says 2.0 chromic catgut, it reaches into the dispenser, holds it for the surgeon to remove it, and so forth. Well, anybody can do a video. So we decided that we were going to build this thing. If I can get to the next... And this is the operating room with no people. It's got a glass wall, so it's a research thing. And here's Da Vinci. Here's the tool changer. This is our scrub nurse, kind of skinny, but very efficient. And over here is our dispenser, if you will. And the system works exactly the same. 2.0 chromic catgut. It gets the sterile suture material and holds it out for the surgeon to remove. When it's finished, they can take it and put it back either in a trash can or on the Mayo stand. Scalpel to the right hand. Gets the scalpel, removes the old one, and places on the new scalpel, and returns it back to the tool changer. Does this all within 11 seconds, and it does it with 99.97% accuracy, which is about as good as my scrub nurse could do, or my circulating nurse. These are systems that we can do today. We don't have to invent anything. All we have to do is take what's available for 25 years in all other industries and begin applying it. So why did the federal government spend that much money in developing an operating room with no people? Well, the idea was that we decided we were going to try to improve upon battlefield casualty care. And instead of bringing the soldier back to the operating room, we were going to take the operating room to the soldier. Because the critical period, you know, the golden hour, now it's the golden 10 minutes or the golden 20 minutes. And so, oh shoot, sorry. So what we did is we developed a system. This is the concept of which the operating room with no people was the first one. Sometimes this takes a while to get started. And so here is a concept that drove the operating room with no people. Take the operating room to the wounded soldier, not the soldier to the operating room. Soldiers are out in the battlefield. An explosion occurs. We have man down. And so we have a number. You could turn the volume up just a tad. What you see there is a robotic extraction vehicle, REX-2. We have 2 of those right now that are in prototype to scoop up the wounded soldier and put him in a robotic armored vehicle that has an operating room. We'll be able to put the patient asleep. We scan them so we can understand exactly what's wrong with them, and the surgeon can begin operating, starting the IV, if you will. And if they need to use instruments, they can change the instruments automatically as we demonstrated. And we're moving more and more, not only from the instruments that are mechanical, but also moving towards instruments that contain energy, if you will. And so here's our mechanical instruments, and we're moving to high-intensity focused ultrasounds, lasers, plasma medicine, and so forth.